then they will introduce the chairperson.
Good afternoon, everybody. I think we should be in time for the next session at 4:15 on achieving a balanced knee through bone, implant and soft tissue modifications. And I would like to invite the conveners on stage, Arun, Mullaji and Pranav Agarwal. Please do come on stage and we should be able to start on time. And I would request them to also invite the chairpersons. Thank you.
Can I invite our panelists, Mr. Gautam Chakrabarty from the UK, Dhanasekara Raja, and Anoop Jhurani. And the person who's going to chair this session, Parag Sancheti. So please join us. We have unfortunately one panelist missing. He's Dr. Gurava. Reddy, he couldn't make it. And we have our three panelists here. And Pranav and I will be taking you through this session on achieving a balanced knee, bone, soft tissue, and implant modifications. Pranav, you'd like to come here? Yes. Yeah, you can also join. All right. So all these cases need surgery. Be brief to the panelists. For each condition, we are going to take the views of the panelists for about 7 minutes, talking to them about the alignment, cuts, releases, and implant. And then we'll have a take-home message by each of them. So let's first get a sense of what our chairperson and the panelists think about whether they use measured resection or gap balancing, starting with Anoop.
So measured resection for deformities less than 10 degrees mostly. So you resect whatever you've lost and replace. But in deformities more than 10 degrees, 15, 20 degrees, gap balancing.
Gap balancing, okay. Any difference? Raja?
Mostly combine measured resection with gap balancing. Extension gap balance first, flexion gap, mostly gap balancing. I change my femoral component rotation according to the flexion gap once my extension gap is balanced.
And Gautam?
A hybrid, bit of both. Definitely measure the what I've resected and replace. So I won't resect less than what the component thickness is, and then adjust the soft tissues to fit around it. I do use a standard rotation of 3 degrees because the jigs that
we'll come to that. Just now we're talking about just the basic concept so that we know where everyone stands. Parag?
So more towards gap balancing.
Okay. Pranav?
I use a combination of both.
Okay, so it's a bit of both. All right. Next, alignment. So we'll start with you, Pranav. What do you do for alignment? We have these various options of alignment now. It's important to get this right and then go into the deformity correction so we can really talk about soft tissue balancing in detail so that we don't need to refer to this again. So Pranav, what sort of alignment do you use? Mechanical, that's 90-90 for your implants and 180 for the hip knee ankle axis.
Yes, that is what I use.
You use mechanical.
Yes, yes.
Parag?
Oh, I am 100% mechanical.
Mechanical. Gautam?
Mechanical.
Mechanical.
Mechanical, and I'm doing conventional. With the advent of robotics, I do some adjusted mechanical as well.
So look at the preoperative phenotype. If it's a mechanical tall male patient with femoral valgus angle 5 degrees, you go for mechanical. If it's constitutional varus with high neck shaft angle, with a bored tibia, bored femur, go for kinematic with the help of navigation or robotics. Okay. And valgoid, be according to the pre-op phenotype.
So you will vary it. I use mostly mechanical with a couple of degrees of varus on the tibia, not more, and then adjust the femur to within 3 degrees, aiming for roughly within 3 degrees of HKA of 180. Okay, what about femoral rotation? Let's start with you, Anoop. How do you rotate the femur? Do you use any of these landmarks or you just use a combination of them?
So transepicondylar axis is my main landmark, but the important thing is to see the wear on the posteromedial condyle. So if it's worn out completely, I would decrease the rotation. Be still parallel, but
so if you're using the TEA, that doesn't matter where the wear is,
That's
really?
Right.
Yeah. What about you, Dr. Raja?
I use the transepicondylar axis and try to match the flexion gap to the jigs and then balancing gap.
So transepicondylar. Gautam?
Transepicondylar, but my more so in a valgus knee. 100% transepicondylar in a valgus knee. Varus knee, I use Anoop's idea of assessing the extent of wear in the posterior medial and perhaps pay less attention to the axis because it fits in correctly.
What about you, Parag?
So parallel to the tibial cut technique, I rotate the femur to make the tibial cut parallel to my posterior cut, and that's how I adjust the rotation.
Okay. I tend to actually take off almost equal amounts from both condyles now. So although I use mechanical alignment for the main coronal axis for rotation, I'm now using more and more of equal resections, and I find that they have a very good flexion gap and excellent flexion as well as the ability to sit cross-legged. And the patella tracking is really not an issue. Okay, now I want to know from you guys how much laxity, when we start talking about balancing a knee, we need to come down to specifics. What do you mean by a balanced knee? So I know we can talk about the whole range of motion, but let's talk about extension and 90-degree flexion. How much laxity do you accept medially, laterally, flexion versus extension? So do you have your extension gaps equally tight as your flexion gaps, everyone? Anyone not doing this?
No, always equal.
Always equal.
Almost always equal gaps.
I differ.
Flexion, extension. You?
Flexion, little bit laxity on the lateral aspect.
On the lateral side. So would you define how much laxity?
So 1.5 to 2 mm.
In flexion on the lateral side.
Yes.
Anoop, any difference?
So 3 millimeters lateral flexion gap, 2 millimeters lateral extension gap.
And this would be for a varus knee, I presume.
For a varus knee.
But for a valgus knee, would you change that?
Yeah, definitely.
What would you do?
The other way
reverse.
around.
The reverse.
The other way around.
Okay. Gautam?
No, because I essentially go for an equal gap. I'm a retainer, so it's very difficult to create an excessive gap unless you put a thinner polyethylene, so I go for an equal gap, both in flexion and extension.
And medial and lateral?
And medial and
in
lateral.
flexion and extension?
Same.
Same.
Equal gaps.
Okay, what about you?
Yes, I agree with that.
Same. And how do you decide your tensions? Is there some method that you use for figuring out your tension?
Just by the feel of it. Just
Feel.
you feel in extension and 90 degrees flexion, then fully it opens equally.
How do you stress it?
So,
do you use a tensioner? Do you use
Manual force. Just by the hands, the manual
with the
force.
hands? Gautam?
spacer blocks, flexion, assess it, extension, put them, because of the type of implant I use, I correct the, put an extra shim in it to accommodate the thickness of the implant, and then a manual feel as Parag's mentioned.
We start with the spacer block, extension and flexion, then with the trial components. With the robot, we have the sensor tensor.
Okay. Anoop?
Yeah, same tensionometer because we use navigation / robotics, so we get objective values on the screen.
Okay. Now let's move on to varus. Okay. So that's a typical case that we all see. So I want you to tell us step by step how you'll deal with this. So that's the full length X-ray. There's a post HT on the left side, nothing done on the right side. These are the close-ups, AP and lateral views. So the questions are going to be really, are you going to do this lady bilateral or staged? Anyone for bilateral simultaneous?
If my anesthetist and the physicians allow me, I'll go for bilateral.
Assuming patient fit.
Bilateral.
Bilateral. Anyone doing unilateral for this?
And in my setup, we do unilateral followed by the second stage at 2 months
Staged.
to 3 months. Yeah, staged.
Okay.
Staggered by 3 to 5 days.
3 to 5 days. Doesn't that have the highest rate of complications?
It's been routine last 20 years. I don't think there's increased complication.
Okay. Anoop?
Bilateral if medically fit.
I would do it staged.
Staged. Okay. Next question is what type of implant would you use for this patient? Again, go back to the x-rays. Anything specific, different?
I'd start.
Anoop, start with you.
So
Your
PS.
standard implant, PS.
Standard PS.
Okay.
PS, probably keep a tibial stem extension if necessary. There is a bone defect.
Okay, perfect. Stem. Gautam.
I'll aim for a CR first with PS as standby. On the right side, I don't think so you'll require a stem. As soon as you cut it to the tip of that medial defect, you'll get a 10 millimeter resection on the lateral side.
So when you see this sort of a case, would you always keep CR and PS? Do you have your inventory?
Yes, we have that on the shelf. I also have the stems and wedges and everything else on the shelf. So I don't have to prepare from that aspect.
Right, because all of us don't have that luxury of having such a large inventory and keeping stems and CR and PS.
So we have
Parag?
an equal number of PS and CRs,
Okay.
but only one set of stems and wedges.
Parag?
Assuming I was using a CR, I don't use, but if it was that I was doing CR knees, definitely this would not be a CR. I would do a PS,
Okay.
which is usually what I do.
Now let's come down to this. When would you use a constraint or a hinge? When would you keep it? For a varus knee, do you use it often or very rarely? All of you.
So for
Start
me,
with you, Gautam. Do you?
I'm not very often at all, not for a varus knee.
Okay.
In a varus knee with recurvatum, I might keep a hinge as a backup. For severe varus with severe lateral opening, I will keep a constraint as a backup.
All right. Now tell me, what exactly are you going to release in this patient? Let's talk about her right knee, okay? The right knee is the more severe one. So now we'll go through the actual release. Anoop, what would you be releasing in order to correct this?
Right. So first of all, deep medial collateral, downsizing of tibia, removal of all osteophytes, especially the hidden osteophyte under the MCL on the femoral side.
Yes.
So once I've done all of that, and I should be able to correct this deformity. If the deformity is less than 10, more than 10 still, then I may choose to do a medial epicondyle or osteotomy, if necessary.
Dr. Raja, anything different?
In these severe deformities, I will go for measured resection. Very difficult to get your gap balancing technique in this. So we will go with the measured resection. Keep releasing the structures, same like what Anoop said. Same structures that Anoop did, but it will be a measured resection technique.
So I do the femur first. I'll complete the femur based on a 5-degree, that's my standard. Then do a measured resection, both femur and tibia. And depending on the residual deformity, after I've decompressed, what I call as decompression of the MCL by taking away all the osteophytes, both from the femoral side and the tibial side, and then start doing sequential releases.
Releasing what? Releasing what?
Sorry,
That's the key question.
Anteromedial capsule, the superficial MCL, but not all the way down, going round to the equator. And if there's a persistent varus after that, they release the deep medial collateral ligament and the posterior medial capsule. But after I've taken all the osteophytes off.
So if you would have asked me this question 5 years ago, I would have done a very extensive release.
No, I'm asking you today, Parag.
Right now the release is less. I'll just do the deep MCL along with the capsule, go posteromedial in a figure of 4 position. And these are the cases, the severe ones especially. I would leave them a little bit tight and, I would cut a little more on the medial side and leave it a little varus. I wouldn't try to really correct it fully. And I would
Now you're talking more about a little kinematic alignment concept.
Yeah.
Okay.
You would like to keep the tibia in a little bit of varus and still maintain an alignment.
Yes, which I wouldn't have done 5 years ago, but over a period of time, my releases have gone down.
Okay, so this is what we did. We used a stem on the right side. Standard releases only the superficial. We don't touch the superficial MCL at all. Just the deep MCL and remove the osteophytes and a posterior medial capsular release, and that should suffice to give you alignment and balance. Very rarely, if there's severe deformity, as mentioned by Anoop, you might need to do a medial sliding osteotomy, like in this particular patient with severe bowing.
So may I ask you and the panelists, what would be the one indication that you would see on an X-ray or during surgery which will give you an indication that you might require a sliding osteotomy?
So when there's typically large extra-articular deformity, bowing on the femur, tibia, I think that's when you would need it, in short. Yeah.
So it's a bowing on the femur with lateral opening. That's where I'll do a femoral sliding. If there is tibial bowing, I'll go for a tibial osteotomy.
And very rarely, if it's so badly stretched out, then I think there's no real option but to use a more constraint. Would you all agree?
Yep.
That would be the way out for this, and even keep a hinge ready. So here we used a more constrained TC3 with bone loss taken care of by a sleeve and stem configuration. All right, so Varus take-home message. Who's going to present that?
Dr. Chakrabarty.
So my remit is on the Varus take-home message. I've got 1 minute, so I'm going to move rather quickly. So understand the degree of deformity. Use Thin Points classification. If you haven't read it, good paper to read. Understand what the tight structures are. Tips and tricks. This should start when you first see the patient. Preoperative assessment and an examination under anesthesia. Your approach, remove the osteophytes, provisional release, accurate bone cuts because I'm a measured resection guy, trial prosthesis, further release as required, implant the definitive prosthesis and insert, and if necessary, a further final adjustment. And the rest of it will be covered later. And that's the summary.
Wow, that didn't take 1 minute even. That was super fast.
I got that.
All right, let's go back to now the next deformity. We'll talk about valgus knees now, which are typically more complex to handle. So let's start with this lady. Pranav, how are you going to deal with this lady? What approach will you use if the patella is subluxated? For example, on the left side, what would you do?
So even so, most of my deformity corrections, most of my TKRs happen from a medial parapatellar approach.
Okay.
I usually use that. Rarely have I used a lateral approach.
Any difference? Yep.
So if I have a fixed valgus more than 10 degrees, I go through a lateral approach. Otherwise, through a medial approach.
And how does that help you?
It gives a direct approach to the lateral structures. The patellar tracking is good. It forms an intraoperative release of the lateral retinaculum. So that way it is good.
Yep.
So just as a matter of point for the audience, the one thing that I do in a valgus knee is try and assess what happens to the knee in 90 degrees of flexion. Because if the valgus actually corrects completely in 90 degrees of flexion, the chances are you will require very little soft tissue release.
We'll
and
come
predominantly,
to the release. We're just talking about the approach now. I'm going to
give
you a chance to talk about
No,
the release.
the one before, just to make sure that there's an examination before we set up and get
started. So before you go to the release, it's important to see whether it corrects in flexion or not. If it corrects in flexion, then more likely you wouldn't require a release. That's a great point. But here we are talking about the approach. Would everyone use a medial parapatellar, any other than Dr. Raja, a lateral approach?
So in this case, I would use a lateral parapatellar because of the patella. Otherwise, my threshold to use a lateral is very, very high. I wouldn't, but because the patella is,
subluxated or dislocated.
I'm anticipating a lateral release, so might as well use a lateral approach.
Perfect. All right. The only thing is the closure is a little more difficult with the lateral approach, especially distally. You've got to be very careful that you don't leave the gap and the capsulotomy is fully closed. So you've got to take care there. All right. So now we come to the releases. So for this lady, what release do you anticipate, let's say on the left side? So here are your structures. So what are you going to release, Anoop?
So as I can see, this is valgus with some degree of hyperextension. It's not valgus with fixed flexion deformity. So IT band would be the first to go. I'll see what my analysis is on navigation screen. If it is still more than 7-8 degrees, then I would go more, remove all the osteophytes, decompress the lateral side, and popliteus.
Do you think removal of osteophytes helps in a valgus knee? Because it's inserted on the fibular head.
Yeah, but decompressing the IT band. Decompressing the IT band.
IT band, yes.
Yeah, it's because the flare really goes lateral and it hits the IT band. So decompressing the IT band. Once that corrects, then I would look at the lateral flexion gap. If it's tight, then I would pie crust or partially tenotomize the popliteus.
The popliteal tendon.
Popliteal tendon, yeah.
Okay, Dr. Raja.
So there are structures which are tight in extension and structures which are tight both in extension and flexion. The IT band and the capsule are tight in extension. So deformity mostly on extension will be corrected with the release of IT band and posterolateral capsulotomy. If these structures are tight even in flexion, that will be due to lateral collateral ligament and popliteus. So that I will do a sliding osteotomy.
Gautam, any thoughts?
Going back to what I said before, assess whether it's tight, what the correction of the deformity in flexion or extension. If the deformity is only in extension, then IT band first, posterolateral capsule, and occasionally you release the popliteus tendon to allow some rotation to take place. If it's the combination of both, that in flexion and extension, you've got a persistent valgus or marginal correction of valgus, then apart from these, you may have to address the lateral collateral ligament, but it's much more rarer to do that. Majority of the times, if you actually examine the knee with the knee in 90 degrees of flexion, you'll find that there is significant correction of the valgus deformity. And that is something that as colleagues, we probably don't do enough. We just ask somebody else to set the patient up. And it's better to actually examine a valgus knee in the anesthetic room and make sure, and you get a much better idea.
You should do that for all your knees. You should examine them under anesthesia,
yes,
irrespective of the...
We probably don't pay as much attention to a varus knee because we think that is easy, but that's wrong. Nothing is easy. Each one of these knees can become very difficult if you've not paid attention.
Parag, specific releases?
Yeah, so in extension, I would do whatever everybody has said, the lateral collateral, the pop fib ligament. In flexion, what I do is by the inside-out technique, I put a laminar spreader at 90 degrees, stretch it, and do pie crusting with the 11 blade. You know, some minimal inside-out releases.
Pie crusting of what? Which structure?
ITB and the lateral collateral, whatever is tight.
Lateral collateral?
Whatever I can feel. You know,
Lateral
I just use a 16-gauge needle or 11 blade, and when I put my laminar spreader, I feel some tight structures, maybe the capsule, maybe the ITB, and I just release that with 6 or 7 stabs.
Does anyone release the lateral collateral ligament in a valgus knee?
We have a show of hands. How many people would release? And in their experience, how many people have had the occasion of going all the way till an LCL release? There are a couple of people there.
Wow. I thought most people don't release the LCL.
Whatever is tight in flexion,
really,
because you palpate
contract.
that, Arun.
Okay.
I have a dysplastic type of valgus, like a childhood
I
deformity.
think most valgus knees will come in alignment if an ITB plus a posterior capsule and the rarest chance a popliteal release is done. Mostly they will settle down.
Correct. So these are the structures. The IT band typically, if it's tight, posterior lateral capsule, and if required, the popliteofibular ligament. If your flexion gap is tight, you don't really need to release the popliteus because it's a stretchable structure. What contracts is the popliteofibular ligament. The moment you do that, you should be able to get complete release. This lady just required minimal releases as described. And this is her 16-year follow-up. And you can see her x-rays are unchanged over the years. Now, if it remains tight, some of you have described what needs to be done. So there's one other possibility that you can do what's called a sliding osteotomy. And here this was extremely rigid. We've done that on both the sides. And very rarely when the MCL is totally stretched out like this, would you require some more level of constraint, right?
Yeah.
You agree with all of that?
That's right.
Okay. Yeah. And these are her post-op images. So the take-home message for valgus is that, as mentioned, you may have a flexion contracture or you may have hyperextension. But it could be rigid, very rarely. Most of the time it's correctable. If the MCL is stretched, then you have to take that into account. Most of the time you don't need to release the LCL, just an ITB release, posterior lateral corner, popliteofibular ligament. And rarely you need to do a lateral epicondylar osteotomy. If it's extremely tight, I prefer to do that rather than releasing the lateral collateral ligament, because in that case your flexion gap becomes unstable laterally. And rarely would you require constraint or a hinge. Now we move on to flexion deformity, and Pranav is going to summarize at the end, right?
Yes, I'll do that.
So now I think you have to differentiate between rheumatoid and osteo. So let's take rheumatoids, which are a little more difficult, like this lady. These are her x-rays, often a little bit of valgus in addition to the flexion deformity. And what you would have is typically an extension gap which is very tight compared to your flexion gap, right? You all agree with that? So now how are we going to do this? Would you do this bilateral? Again, I think we've been through this before, right? If the patient is fit, probably bilateral, otherwise staged.
These patients actually should be done bilateral.
Bilateral if possible.
Fixed flexion deformity cases, because otherwise it's very difficult for them to walk.
Absolutely right. So if they are fit, we should try and do them together. Now, would you give any pre-op physiotherapy to these patients?
No.
Anyone?
No, it doesn't work.
Casting, splinting, wedging the plaster. Pranav?
Is the pre-op physiotherapy in view of getting a betterment of the deformity? Then that doesn't really work.
Okay. So we are all agreed, no real pre-op physio. Now what about your constraint, level of constraint? CR, PS, any thoughts? Anoop?
So PS.
Most of the time.
These 30 degrees can be managed with PS, yeah.
Right. And how many degrees would you go for a hinge or a constraint?
Hinge, I don't think, except for recurvatum deformities, FFDs don't need a hinge.
Ever in an ankylosed knee?
Yeah,
flexion?
ankylosed in flexion, especially if the flexion gap is unmanageable, it's too big, then the extension gap, then maybe.
Then
but
maybe
those are
a hinge.
Very rare cases.
So very rarely, yeah.
So PS, something more than 30 degrees, I'll consider a constraint because there is a chance of mid-flexion instability. So I'll take one level up if I'm correcting severe deformity more than 30 degrees.
So now tell me, Gautam, how are you going to deal with this situation where your extension gap is so tight and your flexion gap is lax or it's bigger? So how are you going to equalize them?
So
that's what we're talking about.
So it depends on how tight it is.
Well, let's say there's a 5 millimeter difference.
Do adequate releases to the posterior releases.
So what would you release posteriorly?
So posterior capsule, elevate that with the help of an or curved osteotome. You put a laminar spreader so that you can actually visualize it, so that you're not doing it blind. I think it's very important not to do it blind. It's also important that when you put a laminar spreader, to be mindful of the fact that particularly in a rheumatoid patient, the bone is very soft. So if you jack it up very quickly and rather ferociously, you're going to cause more bone damage, and you need to be mindful of that as well. Release that. I am a very CR person, so I still aim for a CR, and my PS, going to a PS is as a last resort. Yes, I have that advantage that I have it on the system. So
let's say now you release the capsule. Where are you going to release the capsule?
Of the back of the femur.
Of the back of the femur, using what device or instrument?
I use a curved osteotome, or you can use a Bristow's
or a gouge,
or a gouge, something like that. I have a curved osteotome which fits in very well along the curve of it.
Right, Parag.
Yeah, similar. So if there's a mismatch, what I would not hesitate, I'll increase the distal femoral cut.
Okay, so you will cut the femur. You won't bother too much about
and then I will oversize the femoral component to match the gap.
Anoop?
So it's a mix of everything. 1 or 2 millimeters more resection of the femur. Upsize the femur to snug in the flexion gap. Take off 1 or 2 millimeters
more. By upsize, you mean you want to posteriorize it. Fill the flexion gap, right?
Yeah,
because you can upsize it anteriorly also. You're talking about upsize and bring it down posteriorly.
Downsize and increase the flexion of the femoral component to snug in the flexion space.
So you flex the femoral component and bring it posteriorly to close the flexion gap.
That's right. Take off 1 or 2 millimeter of tibia, then assess and then release with a curved cautery and curved osteotome all around the femur. That will correct the deformity.
Dr. Raja, anything different?
So we'll start with the tibial cut, distal femoral cut standard. Release the PCL and go for the sizing. If you get an in-between size, I'll go for a higher size. We'll do the posterior condylar resection. I won't finalize the chamfer cuts. Do the capsule release. Put your spacer block in. If you're able to correct the deformity.
Make sure you don't release the capsule in the midline, right?
Sir, I have 2 questions.
Yeah.
One is, how many of the panelists would dial in a 2 millimeter extra cut on the femoral side, the distal femur, right from the beginning? You would do it, sir.
I do it as a routine.
Doing it. No, you should, forgive me, you should try and refrain from doing it because you can get mid-flexion instability.
True.
So you must first release the capsule. If you're unable to do so, you should not do it as the first step. That's my thought process.
So in my experience, I actually move the block, the system that I use, although it's meant to cut 9 millimeter, it never cuts 9 millimeter. Okay. It always cuts 7. So you always get an extension tightness. So I've always migrate to adding 2 more millimeters right from the beginning so that I get my measured resection of 9 millimeters. So rather than confusing the nursing staff, I do it myself.
Okay.
I've taken 2 millimeters off, but I've not actually taken any excess bone off. It's just that the system does not cut what it says it'll do.
Right.
And when you use a CR knee in a fixed flexion deformity associated with another deformity, how many times have you had to revisit and probably do a release of the PCL or increase the posterior slope of the tibia?
Good question. So if that's particularly when I get the posterior slope not quite right. Now again, it's a little bit system bias where the system is so clumsy at the bottom end that it gives you, there's an inherently built-in slope after 0 degrees, but it doesn't give you a 0 degree slope. And in some cases, it works differently. In an Asian knee, particularly, it's bad because Asian knees inherently have got an increased amount of slope as opposed to a Caucasian knee. In a Caucasian knee, the natural slope is less than an Asian knee, and that makes a lot of difference. So here Here I've seen that colleagues put a slightly increased slope than I would do in ecchocation near the root.
But I think in a flexion contracture, you've got to be a little careful with taking too much of the posterior part of the tibia. I think you should reduce the slope, not increase it.
That's right.
Irrespective of, whether it's Asian or Caucasian, I think.
That's
because you're just increasing your flexion gap.
So
All right. So in the interest of time, these are the three options you have: posterior capsulotomy, release the gastroc sometimes if it's really tight, and resect more of the distal femur. So these are the patients post-op X-rays. Now, how do you treat them post-op? Any splintage, slab, and what complications will you look for before you leave the OR? Anoop.
I'll carefully look at the pulse. That's the first thing. And once the patient is out of anesthesia, I would look at the peroneal nerve, especially with FFD with valgus cases. And I would try and correct them fully, at least to 3, 4, 5 degrees, never more than 5 degrees. I will let go.
Excellent point. Anything else in terms of post-op care?
So I'll definitely give a back slab. I have something like a push knee splint.
Push knee splint.
To correct the residual flexion deformity.
Often these patients have quad weakness along with their flexion contracture, and they would need probably electrical stimulation and physiotherapy for a prolonged period to prevent recurrence. These are the patient's images at 2 years. Now, what if you had something even more severe like this, 75 degrees? Is there anything additional that you would do to correct this?
Yes, percutaneous tenotomy of the hams.
Anyone else?
Could you also tell us when would you do this? Intra-procedure, during the time of the surgery?
Yeah, during the procedure.
You'll turn the patient around and then do it?
No, you can do it from the side.
You can do it from the side, and that's exactly what we've done here. Posterior tenotomies, percutaneous, like you do for a CP child, you can do a tenotomy.
Yeah.
All right. Now, any difference with osteoarthritic patients with FD?
Yeah, definitely. Osteoarthritic patient, I would never leave him in flexion on table. I will make all efforts to make sure that the flexion deformity in osteoarthritic knee is corrected. But if it is rheumatoid, it'll stretch out.
Yeah,
by
so
10
that's
degrees,
why
I would accept that.
I think the capsular release, etc., is really required more for rheumatoid patients and less so for OA patients, where if you remove the osteophytes, you should be in a good shape to get full correction. So over to Pranav, a quick summary of flexion deformities.
Can we have a change in presentation, please? So in interest of time, I'll just go through this one algorithm on the left-hand side of the screen. We've already discussed that it's important to do soft tissue releases before we go in for a distal femoral cut. In this particular case, where we have when we are dealing with, cruciate retaining knees, if the extension gap at some point is not equal to the flexion gap, then we can address it using increase in posterior tibial slope and releasing the PCL a bit. If that doesn't work, then we must convert to a PS knee. This is the algorithm that I would follow because I usually do PS knees. Osteophyte removal in an OA knee is definitely necessary because that causes the tenting. Then correct the coronal deformity. Release gastrocnemius from the posterior aspect of the femur. Divide the capsule at the level of the joint line or towards the tibial cut. Then femoral component can be used to either flex, either increase in size or posteriorly translate. Then if at all it doesn't solve, then we go in for a distal femoral cut, and in case of very severe deformities, fractional lengthening of the posterior structures. So that's the small summary.
Great. So that summarizes basically the steps in a flexion contracture. And if we go back now to another fairly difficult deformity to deal with, and that's hyperextension. Can we? Yeah. Okay. So in hyperextension, do you think it's commonly missed or it's very rarely seen? Is it uncommon or commonly missed?
It's very common. It's very common, and we should examine the patients carefully during gait and after anesthesia. It usually unmasks itself after anesthesia.
That's a great point, and most people actually can see a flexion contracture because you can see the leg rotated and there's a gap behind the knee. But unless you lift the foot up, you're not going to see a hyperextension deformity, which is why it's commonly missed. What are the other things you would like to evaluate preoperatively in patients with severe hyperextension?
Neuropathy, especially diabetes, or any occult neuropathic joint. So that's what one should rule out, especially in recurvatum more than 10 degrees.
Dr. Raja?
Generalized ligament laxity. You need to examine other joints. It can be familial also. I have two sisters, both have hyperextension. So that the second sister, I put additional distal femoral augment to make it tight. Neurology, these are things.
Gautam?
So I agree with everything that's been said, but what is important to also recognize that there is an element of physiological hyperextension. Some of us have got inbuilt hyperextension, but no pathology in the joint. But when it comes to doing a knee replacement on such patients, you need to be mindful of that you don't place the implant into hyperextension and let the knee go into hyperextension. Right. And in that case, it is probably better to resect less or build up as a...
So we come to that, yeah. And what about spinal problems? How often do you see patients with spinal canal stenosis having hyperextension? I think it's a very commonly missed problem.
That's right, yeah.
Parag, any other thoughts?
Also, just the neurological disorders, some of these patients who have residual polio or, other disorders, we should rule them out. We should find out what is the level of the muscle weakness. And I always send these patients for an EMG nerve conduction study when I see a patient.
Excellent point. So when you see hyperextension, you've got to be rather careful of the neurological condition. So now this is a guy with flexion on one side and hyperextension on the other side. You can see the X-ray down below. So now this is the fundamental problem, right? Your extension gap is huge and your flexion gap is less compared to the extension gap. So how are you going to balance this, Anoop?
So typically it will be less distal femur resection, at least 2 or 3 millimeters less, and these knees are globally lax. So you need to resect less of tibia, maybe 4 or 5 millimeters is enough to snug in both the gaps. And you leave them a little tight, maybe 5 degrees of flexion.
Dr. Raja, any other additional features?
Valgus deformity can have hyperextension because of the bone loss on the distal femur and tightness of the IT band. The IT band axis shifts anterior to the knee joint, it becomes a hyperextensive force.
So release IT band?
Yes.
Yes. And Dr. Gautam?
No, nothing different.
Nothing different.
The most important bit is the resection level has to be less than in a varus.
Take off less, do no release at all, especially at the back of the knee.
In a valgus with a hyperextension deformity, would you change the cut of the distal femur vis-a-vis the mechanical and anatomical axis of the femur, or would you still cut it in 5 or 6 degrees valgus?
No, I do individualize valgus correction angle. For the particular patient, what is the valgus correction angle? I do the same. Even distal resection, I don't change.
I think that is Sir's paper on the valgus correction angle.
So that is the common thing, and we've heard Dr. Ranavat say many times, cut just 3 degrees. But I particularly don't agree with that, to be honest. It's you measure what it is, the difference, what it is in the mechanical and anatomical axis, and get your valgus, match it to that. It's not like just 3 degree for valgus. I don't do that. Yeah.
So you would just build up the hypoplastic lateral condyle if it were to be there.
All right. So essentially the other thing you can do is to downsize the femoral component so that you enlarge your flexion gap, as it were, and try and match it to your flexion gap. So you might wish to downsize the femur by 1 size perhaps, and that'll help you to equalize your gaps. So this is the intra-op appearance of this patient. And typically, how much would you like to leave them slightly flexed, neutral, or hyperextended slightly at the end of the procedure? What would you like to see them?
Neutral.
Little flexed.
Little flexed. 3 or 4 degrees flexion.
3 to 5 degrees.
5 degrees.
Yeah, so leave them in few degrees of flexion. And what would you do post-op? How do you manage them? Any particular splintage, any particular positioning?
Ask them to keep a pillow under the knee, but Most of them don't comply, I think, but that's one thing.
Yeah,
I think it's easier for them to comply for a pillow under the knee rather than under the ankle. I've seen most patients happy to keep a pillow under the knee.
Absolutely. So they're very happy with the pillow under the knee for these type of cases, and I'm happy as well. And probably refrain from static quads exercises. You can get them to do active SLR, strengthening the quads, but try and avoid getting them to reduce the gap behind the knee. So this is a patient post-op. Hyperextension, who's going to summarize? Dr. Raja.
And we have the next presentation, please.
And then that'll bring us in time for the revision session.
So hyperextension, we look at etiology. Could be inflammatory arthritis combined with valgus deformity. You can have a neuromuscular deformity or a neuropathic arthritis. So under resection, we have discussed. If necessary, we can augment the distal femur in severe hyperextension deformities. In valgus deformity, you correct the valgus deformity and build up the distal femur, you will be able to correct it. In neuropathic arthritis, we discussed, we assess joint position and vibration sense, MRI of the spine and nerve conduction study. If the cortices power is good, we do a TC3 rotating platform knee. If it is severe neuropathic arthritis with corticeps weakness, we go for a hinge type of joint. Thank you.
That was brilliant, Dr. Raja. Excellent. Okay, so can we go back now to the last section, which is now talking about revisions and how do we go around balancing the failed knee. So this is a patient who had a valgus deformity to start with. This was operated somewhere else. And you can see that this valgus knee has gone into varus on the full-length X-ray. You can see the gap opening up laterally. So let's first dissect the causes for this failure. Why is this knee unstable? Parag, any thoughts?
So I'll have to work up the patient. Is there infection?
No, we rule out all those things.
So
now
then,
we're talking about instability here.
So now we can see it's obviously it's loose, so it may be malalignment, which has led to this early poly failure, leading to wear and loosening. And you find out what are the other causes. So this is what I would do to work up this patient. I would also keep in mind, your poly which has been used is quite thick. And there may be a mismatch between the flexion extension gaps, so which also can be a cause for early failure.
Gautam, any thoughts on the X-ray?
So, if possible, I'd like to see the pre-op X-ray, but presume that it's not available. No, pre-op. The pre.
You mean immediate post-op?
Oh, okay, it's on the valgus. So the basic problem here is the tibial cut, and the alignment of the tibial cut is. There's increased resection on the medial side to the extent that the entire tibial component has gone into increased amount of varus. Subsequently, the femoral component has been planned based on the tibial cut, so the whole alignment has changed, and there has been an excessive release on the medial side, which is why it has failed. How do we, assuming everything is normal, rebuild the tibia first?
One moment. What we do next is in a moment. Dr. Raja, do you agree with the analysis? Why is this knee unstable?
So valgus knee has been overcorrected. Tibial component has been cut in varus. These are two things which has led to failure. Gap balancing, soft tissue balancing not correct, probably over-release on the lateral side and tibial component in varus.
What do you say, Anoop? What's the size of the femoral component like?
Yeah, so I think the size of the poly gives us an idea what happened on the table. Probably led to instability, over-release on the lateral side. Malalignment and instability often go together. And I think this is the case where both are going together.
So you can see that the posterior offset of the femoral component is very small. So you can see they have undersized the femoral component, so they had a very large flexion gap. So they put in a huge poly and then did a release to fit that in probably and made it more unstable. And then it's subsequently led to wear and loosening. So there's no infection. So now how will you proceed? Pranav, any thoughts?
So this will need to undergo revision after the entire...
Yeah, so what do you revise it? How will you revise? So now in revision you have, when you remove the implant, this is the situation you face, right? You've got to take those implants out. typically your flexion gap is going to be larger than your extension gap. Is that a general statement that can be made?
Most cases, right? In this particular case, it may have been equal, so it's easier perhaps. But most of the times, your flexion gap exceeds your extension gap, right? Now, how will you balance it?
So first, we go in for removal of implants, go in for the tibial resurfacing, then look at removal of the femoral implant, look at the flexion gap, then the extension gap,
so now we've
build
got
the
flexion
gap
here.
first.
Now we have these gaps. How are you going to balance this knee now? Are you going to use constrained, hinge, thicker inserts? How are you going to get the gaps?
The hinge would be used if there is any laxity in the collateral ligaments. I wouldn't use a
so
hinge,
no hinge.
unless.
All right.
So metal wedges and bone grafts, if necessary.
So what are the metal wedges going to be used on the tibia, on the
Posterior aspect of the femur at the moment.
posterior aspect of the femur? So you're going to rebuild the posterior condylar offset, right, with augments. Would everyone agree with that? Any difference, Gautam?
No, it's a question of posteriorizing the femur and perhaps distalizing it as well at the same time. That will allow you to close a little bit of the gap and allow the patella as well to go up.
So you're now talking about joint line restoration. So in revisions, you need to get your joint line more or less restored to what it should be.
Yeah.
And you could either do that by just putting in thicker and thicker inserts, or you could bring the joint line to the correct level, right, by using augments. Is that what you're saying, Gautam?
Yes, so distalize the femoral component and posteriorize it at the same time, because posteriorization will pick up the increased laxity on the flexion space.
Dr. Raja, any other views?
So the tibial side, I might need a medial wedge because the tibia is in varus. When you're correcting the varus, you will have medial defect. We might need to add a medial wedge with a stem. Femoral side, I will build up the posterior condyle with posterior augments, and if necessary, distal augments as we go.
Okay.
How would we look for restoration of joint line intraoperatively?
So for that, you need to actually,
look at the meniscal remnant, if you can find it there. Or the other way is to distalize it 2.5 centimeters below the medial epicondyle. That's where the joint line is.
These are the cases I would like to go one level higher of constraint, keep a TC3 or LCCK ready.
So here we were able to get away with the PS knee because there's no fundamental problem with your collaterals, and you can balance the gaps quite well. We've had to use a full thickness augment on the tibia in order to reduce the extension gap. Now for this, I think there would be no option but to use a hinge. So we're all in agreement, when the collateral is completely gone, then you need to revise to a hinge. And that's what we did. So who's going to, I think Dr. Anoop will come and tell us quickly how to summarize, how will you balance knee in revision.
All right, so first of all, analyze the range of movement. If it's a stiff knee, especially knee which bends less than 90 degrees, you may need a tibial tubercle osteotomy, which is a useful adjunct to balance the knee, because if it's associated with patella baha, you can actually proximalize the TTO to ensure that you get decent range of motion. So that's first. Second thing is clear the lateral and the medial gutters. Do a prophylactic lateral release, especially if it's tight stiff knee with a spacer in situ. That will give good mobilization of the patella. Tibial cut first with an intramedullary jig, and ensure you remove the cement completely before you put the intramedullary jig. Don't cut too much of tibia, just a couple of millimeters, usually from the lateral aspect. Upsize on the femur, because usually the flexion gap is more. Rotation parallel to the interepicondylar axis and parallel to tibia. Most important, use offset stems if possible to posteriorize the femur and lateralize the femur. So the position of the implant is dictated by the stems. So use that to your advantage by posteriorizing the femur and lateralizing, and same on the tibia. So this case example, you can see that we have used the offset, anteriorized the offset to posteriorize the femur. That snugs is the flexion gap and leaves a good patellar femoral compartment for good mobility of the knee. Thank you very much.
Excellent. So thanks, Pranav. If you'd like to use the mic and just...
Thank you so much. Dr. Mullaji sir for moderating this lovely session. Thank you all our panelists, Dr. Anoop Jhurani, Dr. Dhanasekara Raja, Dr. Gautam Chakrabarty, Chairperson Dr. Parag Sancheti. Thank you so much for being here, and thank you everyone for a patient hearing.
Thank you very much for putting up with this torture.
Thanks, Arun. You did a great job like always.